Good afternoon, everyone. Welcome to our webinar today. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. Today, our webinar is going to focus on myeloma physiotherapy consensus recommendations, what patients and caregivers need to know. Before we get to the presentation and our presenter, I'll just go over a few slides with you. I'd like to first and foremost thank our sponsors for helping us being able to provide these to the myeloma community. So thank you to Amgen, Binding Site, BMS, Janssen, Takeda, and Sanofi. As many of you know, all of our webinars are recorded. If you're going to get some information today, and you might want to look over it a few times or double check something that perhaps you misunderstood. So looking at the recording is a good way to do that. So to access our recordings, you go to youtube.com, or on your tablet or on your phone, you click on the YouTube app. In the search bar, you put Myeloma Canada. You'll find our channel. Once you find our channel, you can click on subscribe. And then once you subscribe, you could also click on the little bell. That little bell, every time we put a new video online, you'll get a notification. And that's a good way to stay up to date with all of the educational presentations that we're providing. You can also, from our website, access these recordings. So if you go to myeloma.ca and you click on the resources button, another menu will open up. Click on educational videos, and that will simply just send you over to our YouTube channel. It's just an easier way of getting there. So after the presentation, we're going to field some questions. So I urge you to, during the presentations, please type in your questions. You can do that using the questions function on the PC or the computer, as well as on your tablet. So what you're seeing on the screen is what it looks like on a computer, but on your tablet it'll be simple. It'll just be a little questions button. You type in your question, you press send. I'll receive the questions. I'm going to ask them at the end to our presenter, and we'll have a discussion about that question and so on and so forth. And so please, as you think of questions, please send them in, and that way at the end of the webinar, we'll be prepared with some questions. So without further ado, I'd like to introduce to you our presenter today. Her name is Deepa Jeevanantham, and she is a registered physiotherapist at Health Sciences North. Also assistant clinical professor at Northern Ontario School of Medicine, and an adjunct professor at the School of Kinesiology and Health Sciences. All of this part of Laurentian University in Sudbury, Ontario. Deepa, thank you so much for joining us today.
Thank you, Gabriel. Thank you for introducing me. Thank you for helping me to do my presentation today. Today, we are going to talk about the physiotherapy guidelines that we developed in Canada, and the recommendations that we provided, that we developed for physiotherapists, so that the patients and the caregivers can know what the recommendations, what are actually recommended for them during their admission at the hospital, and before and after and during they receive stem cell transplantation. This helps the patients and the caregivers to have more confidence and participate more, thereby their quality of their life can be improved, and their physical, their functional performance will also be improved. As Gabriel explained, my name is Deepa Jeevanantham. I'm a physiotherapist. I'm currently working at Health Sciences North. The principal investigator of this research project is Dr. Andrew Knight. He's an oncology physician, and I would like to mention the other co-investigators who are involved in this research project. Venkateshan Rajendran, Dr. Venkateshan Rajendran, Dr. Celine Lariviere, and Dr. Lynn Trombley. Myself and Venkateshan Rajendran oversaw the execution of the project in our hospital, along with Dr. Andrew Knight, and Dr. Celine Lariviere and Dr. Lynn Trombley are our collaborators at Laurentian University. They have been helping us and providing us input as needed. This project was funded by NOVAMA, that is Northern Ontario Academic Medicine Association, and it was executed in the Health Sciences North. Before we go deep into the guidelines, I would like to talk a little bit about multiple myeloma. Multiple myeloma, it's a malignancy of plasma cells. Plasma cells are primarily present in the bone marrow. So the bone marrow is the place where red blood cells, white blood cells, and platelets are all produced, and this process is called hematopoiesis. The malignancy of the plasma cells disrupts the ability of the plasma cells to produce white blood cells, WBCs, RBC, and the platelets. And eventually, it deprives the ability of the bone marrow to produce healthy blood cells, resulting in abnormal hematopoiesis. So in addition to causing this disruption in the hematopoietic system, it also produces proteins, a few proteins called DKK1, IL3, HGF, and TGF, those kind of proteins, which inhibits the formation of osteoblasts. Our bone matrix, or in our bone matrix, there are two processes of two types of cells that are constantly producing. One is osteoblastic cells, and the other one is osteoclastic. Osteoblastic cells helps to form bones, and osteoclast resorbs the bone. The main function of osteoclast is to resorb the dead bone cells. So what happens here is few proteins inhibits the formation of osteoblasts, so there are less bone formation cells, and it also increases formation of osteoclastic cells, so there is less bones and more resorptions. So this disrupts causes destruction of the bony matrix, putting the bone making the bone susceptible for fractures. About 1.2% of total new cases of cancer in women is or multiple myeloma, and multiple myeloma also accounts for 1.6% of total new cases of cancer in men. The incidence rate of multiple myeloma is 3 times higher in more developed countries compared to lesser developed countries. And the median age at which multiple myeloma is usually diagnosed is 69 years. And the median survival rate is 3 to 4 years, depending on their severity. Typically, patients with multiple myeloma present with few symptoms. So the first symptom is hypercalcemia. Hypercalcemia is an increased level of calcium in the blood. This primarily occurs because of the mechanism I was talking to you a little earlier about the increased osteoclastic activity. So bone resorption that causes increased amount of calcium in the blood. So when there is an increased amount of calcium in the blood, it affects the kidney's process to excrete it. So it affects the kidney as well, resulting in renal insufficiency. Plus, multiple myeloma also affects the hematopoietic system, thereby affecting the formation of healthy red blood cells, resulting in anemia. And it also results in bony lesions. Patients may have bone pain, they may have pathological fracture, and sometimes they may have spinal cord compression as well. In addition, patients may also present with fatigue, weakness, and pancytopenia. Typically, there are 3 types of treatments that are typically recommended for patients with multiple myeloma: radiation therapy, chemotherapy, and stem cell transplantation. And side effects of these treatments includes, not limited to, patients may end up with neutropenia, thrombocytopenia, nausea, vomiting, diarrhea, heartburn, mouth sores, skin rashes, and hair loss. Typically, when the patients are admitted in the hospital for treatment, they usually stay in the hospital for about 2 to 3 weeks. During their time of stay at the hospital, they typically tend to spend most of the time in bed, maximum they do is walk to the bathroom, and they which reduces their activity level, thereby resulting in muscular inactivity. So prolonged time, spending long time in bed, an increased level of muscular inactivity in their older age, the cancer-related fatigue, and the treatment and the effects of the treatment itself, all can cause a significant declination in the patient's functional status and their physical performance. So our goal was to develop evidence-based guidelines for two research questions. One is physiotherapy management of weakness and fatigue in patients with multiple myeloma who are receiving chemotherapy and stem cell transplantation. The second question was guidelines for physiotherapist supervised mobilization and exercise intervention of patients with multiple myeloma in acute care setting. So our goal was to do a systematic reviews and then find the available evidence and develop the guidelines. So evidence-based guidelines are basically systematically developed statements to support our work. And there are a few steps that are commonly involved when we develop guidelines. They are identifying the evidence, critical appraisal of the available evidence, and then grading the quality of the available evidence and developing action statements. So before doing the in-depth search, we did a quick scoping review to see what's available in the literature. So a quick search was literature search was conducted on PubMed, Embase, Sinahal, EBSCO, Web of Science, DARE, Cochrane Database of Systematic Review, and PEDRO. And we found that there were quite a bit of evidence was available for research question 1, that is physiotherapy guidelines for patients who received who are receiving chemotherapy and stem cell transplantation. Whereas we couldn't find much of an evidence supporting our research question 2, that is physiotherapy recommendations for patients who are admitted at the hospital. So we used a Delphi technique, which is a consensus-based process for research question 2, and we used literature search plus Delphi technique, which is consensus-based process, like available evidence along with the consensus process from the experts. So the methodology used was we did a detailed database searches on the on multiple search engines using combination of words, because multiple myeloma is referred by different terms like plasma cell myeloma, or hematological cancer. So we use different terminologies, and also for physiotherapy, there are different terminologies like physiotherapy, physical therapy, ambulation, training, exercise. So we used a combination of words to do a detailed research so that we were able to identify majority of the evidence that are available to support our action statements. You can access the full consensus article in this link. Sorry. Okay. So I'm actually presenting in my office, so you might see some people walking by. Sorry about that. So we were able to identify quite a lot of article. I'm unable to see the numbers here. So I'm just going to refer to this article so that I can read the numbers correctly. Yeah. So we were able to identify a total number of 48,060 articles during the search engine. So this database search was done by one independent reviewer. So next step was to remove the duplicates. So we were able to remove 19,381 articles. So we were left with 28,675 articles. So starting from this phase, we had two independent reviewers doing the screening process. So phase one screening process included screening based on abstracts and titles. So they two independent reviewers read the abstracts and the titles and made sure whether the article fit into our inclusion and exclusion criteria. So if the article was fit the inclusion exclusion criteria, then they included it. And each article was included only if both the reviewers accepted. So when there was discrepancy, a third reviewer came in, and at least two of the reviewers should accept an article to be included in the study. So phase two was full text screening, and in this phase we ended up with 124 articles. So once we did the full text reviewing, we were able to include we were able to exclude 109 articles, and we also did a gray literature search, which is basically doing a search of the reference section of the included articles. So finally, we identified 17 articles that supported our research questions. The information from 17 research articles were extracted into a spreadsheet, Excel spreadsheet, and we used a template that was proposed by the Cochrane Public Health Group. And first, before using this data extraction sheet, we pilot tested the data extraction sheet based on using two articles, and it was revised based on the data extraction sheet was revised based on input from our team members. So the data we included in the data extraction forms are, we included general study details like the title, the authors, sources, the country of the study, publication type, and the year of publication. And we also include other study details like the study eligibility, like the type of the study, the participants that participated in each study, the characteristics, number of participants, their age group, their gender, their diagnosis, the type of cancer treatment they were receiving, the stage of the cancer, inclusion, inclusion and exclusion criteria of every single article, the settings in which the study was performed, and the method of allocation to each group they were using, the blinding, the sampling, the type of sampling they used, and whether the patient adhered to the study, or like did they have loss of study patients, and the intervention, like including the type of exercise that was performed, and the type of outcome measures that were used in each article. And we also included other details like duration, program length, who provided the intervention, and the co-interventions that were provided as a part of the research, of that particular article, and the results of the study. So once we extracted all the information that are required for us, we did a critical appraisal process, and this process was done based on standardized critical appraisal tools that were recommended by the American Physical Therapy Association. And this process is necessary to ensure quality and appropriateness of the studies that are included for our process. And primarily, we used 5 tools. One is the Pedro scale. The other one is called MINUS, the methodological index for non-randomized study. Because in our study, we included different types of study, we tried to use different types of standardized tools, methodological assessment tools, to make sure that the studies which we included are quality studies. And we used a CAST checklist, and any systematic reviews that were included in the study was assessed by Amstor scale, and any guidelines that were used in this study were appraised using agreed to scale. Here is the details of each study included and their score based on the methodological assessment. So if you see, most of the studies were good quality studies, and few were case series, and few were cases. We had 2 case studies, and we had quite a number of experimental studies, RCTs. So for our study, we used this table as a guidance for us to see the level of evidence that was available to us. So if I'm unable to see this clearly, so I'm going to refer to tables I have here so that I can read it. Okay. So if the critical appraisal score, the one which we saw in the previous slide, if the score was more than 50% of the criteria, then the study is deemed as level 1 study. If the critical appraisal score was less than 50%, example 4 out of 10. If the score is less, then that particular study will be deemed as level 2 studies. And any case control studies and retrospective studies, they're deemed as level 3. And case studies and case series were deemed as level 4. And expert opinion, where we don't have enough evidence to support, but when it's based on a particular clinician's or an expert's opinion, then that particular study will be deemed as level 5. So in addition, we also used grades, which is a grading of recommendations and action statements for based on Kaplan and colleagues. So this helps us to identify how strong our recommendations were. So based on this, if we use level 1 study, then the level, if our recommendations are based on level 1, then our recommendations are like grade A, which is strong recommendation. If we used mostly level 2 studies, then our recommendation was grade B, was deemed grade B, which means a moderate recommendation. So if we have only one level 2 study, and if when we had predominance of level 3 and 4 studies, then the action statement was deemed as grade C, which is a weaker recommendations. And like this helps us to modify the words, the wordings of the action statements. Example, if we say may, maybe it's moderate or weak. If we say must or should, then that statement is based on stronger recommendations. So the next methodology which we use for our research projects is the Delphi process. Delphi process is a structured and effective way of getting consensus from group of experts, and it's an excellent technique for group agreement and decision making. It's been found to be effective in guideline development, and it's the main focus. So the main methodology behind this is like a focus group response. For our project, we used Delphi process in 2 phases, phase 1 and phase 2. Phase 1 included 10 registered physiotherapists across Canada, and phase 2 included 10 patients with multiple myeloma, and those 10 patients were recruited at Health Sciences North. Coming to the recommendations which we propose, that are proposed in our research, in our guidelines are, first recommendation is based on whether it's about whether a physiotherapy session should be withheld based on lower hemoglobin values. Hemoglobins are basically red blood cells, which the main function of the RBC is to carry oxygen to the cells. When the hemoglobins are lower than 12 in women, and if it's less than 13 in men, then they're diagnosed as anemia. So anemia is pretty common in multiple myeloma, and anemia in multiple myeloma is caused by the malignancy itself because of the abnormal hematopoietic system and cancer treatment as well. We have to remember that not all patients with anemia are symptomatic, and hemoglobin levels are one of the majority laboratory values which a physiotherapist takes into consideration before mobilizing patients in the acute care setting. And it is recommended that physiotherapy intervention should not be automatically withheld just because hemoglobin levels are lower. Decisions should be made based on their complete presentations, how their vital signs are, and how symptomatic they are. Because withholding physiotherapy intervention can negatively affect the patient's mobility, can affect their overall health status, and it can also increase the length of hospital stay. So physiotherapists use their discretion before withholding physiotherapy intervention for patients with multiple myeloma with lower hemoglobin levels. So the second statement is about how physiotherapy intervention should be provided for patients with lower hemoglobin levels. So our recommendation is that well-monitored physical therapy intervention can be safely administered to patients with multiple myeloma with hemoglobin levels that are lower than 8 in consultation with a physician while carefully monitoring their vital signs and the signs of adverse events. Before administering physiotherapy, during the administration of the physiotherapy, and after the administration of the physiotherapy. And physiotherapy intervention is generally contraindicated in patients with hemoglobin levels that are lesser than 8. Usually, patients with anemia typically receive blood transfusions primarily to maintain their oxygen delivery. Peterson et al., so a group of scientists, they did a retrospective study to analyze the effect of physiotherapy intervention when they provided physiotherapy for patients who had lower hemoglobin levels. And they recommend that physiotherapy session be withheld for patients who have hemoglobin levels that are less than 7 and not less than 8. And because evidence shows that critically ill patients with hemoglobin levels as low as 7 can tolerate physiotherapy interventions. However, it's important to remember that patients with cardiac and respiratory conditions are at a higher risk of compromised cardiac output and desaturation. So physiotherapists have to use their discretion and have to consider the other factors which the patient has and make recommendation based on that. So, and it's all in it, and it's also recommended, strongly recommend that physiotherapists liaise with physicians before delivering physiotherapy interventions and discuss any additional signs to monitor during physiotherapy sessions. And it's very important that they monitor for signs of adverse reactions. I'm just going to list few. It's more than that. I'm just going to list few. Chest pain, discoloration, pallor, leg cramps, dizziness, shortness of breath, respiratory distress, and any positive orthostatic response. And they have to closely monitor when they provide physiotherapy intervention. And the next statement is about providing physiotherapy intervention during RBC transfusions. A well-monitored physiotherapy intervention can be provided to patients with multiple myeloma who are receiving RBC blood transfusion by carefully monitoring vital signs and complete presentation of the patients and the signs of adverse events. Patients with multiple myeloma typically receive blood transfusion when their hemoglobin is lower than 7. In stable individuals, whereas they might receive RBC transfusion when they have less than when their hemoglobin levels are less than 8, when they have cardiac issues. So when they do the transfusion, patients may receive a transfusion for approximately 2 hours to several hours, depending on the number of units they are receiving. So withholding physiotherapy solely because they are receiving RBC transfusion might affect the patient's mobility status and their functional performance. So, and Rosenfeld et al. Examined the safety of administering physiotherapy intervention in patients with hematological malignancy who are receiving RBC transfusion, and found that patients receiving physiotherapy intervention during RBC transfusion did not have any adverse effects. And they recommend that patients be closely monitored for abnormal vital signs. In addition to the adverse effects, they should also look into the be careful about the other things like dislodging of the IV site and the syncope and reaction to blood products, because you're currently receiving the blood products. So in addition to the symptoms, the symptoms that are related to multiple myeloma, they should also be monitoring for symptoms that are related to blood transfusion reactions. Next, I'm going to talk about the platelets. A well-monitored individualized physiotherapy intervention may be provided in patients with the platelets greater than 10 after consultation with the physician. When the platelet counts are less than 10,000, when it's less than 10, it's important to stick to the essential ambulation with assistance or with supervision and gentle range of motion exercises in lying or in sitting without straining. And if there is any signs of, if the exercises can be performed if there is no signs of bleeding or no history of recent bleeding. So when the platelet counts are between 10 and 20, gentle range of motion exercises, strength training exercises without resistance in sitting, lying, and standing can be performed, and patients can be walked as tolerated if there is no signs of bleeding or no history of recent bleeding. So when the platelets are between 20 and 40, light resistance exercises using elastic bands can be performed, again if there is no signs of bleeding or no history of recent bleeding. And when the platelets levels are greater than 40, then gentle aerobic exercises like stationary biking can also be performed, again if there is no signs of bleeding or no history of recent bleeding. Physical therapists should also educate patients about the risk of fall, risk of bleeding, signs of bleeding, the caution against injury, and they should also be wearing proper clothing and proper footwear and compliance that are recommended by and they should be compliant to the recommendations that are provided by the healthcare professionals. Example, if the healthcare provided, if a physiotherapist recommends any use of assistive devices or any use of supervision, should be followed. And during the execution of the exercise program, physiotherapist should monitor for signs of bleeding, such as nose bleeding, gum bleeding, bruising, petechiae, any swelling, and also signs of intracranial bleeding, any signs of gastrointestinal bleeding. So should be, especially when the platelet counts are less than 10, it is very important that the physiotherapist monitors, looks for the signs before administering physiotherapy, during administering physiotherapy, and after administering physiotherapy program. And the normal platelet counts range from 150 to 450, and bleeding time is typically not prolonged until the platelets are count is below 100. So thrombocytopenia refers to platelet counts that fall well under the normal range. Typically, platelet counts may drop following chemotherapy, with the lowest count occurring between 7 to 10 days post-chemotherapy, and it may take 2 to 3 weeks to recover. So while bed rest is important in preventing bleeding, 2 to 3 weeks of bed rest may cause significant functional declination in older adults, especially older adults with multiple myeloma. Therefore, it is important to weigh the benefits and the harms of doing exercises to prevent functional declination. However, there is a lack of empirical evidence on safe exercise or physical activity according to the cut points for multiple myeloma with thrombocytopenia. So the recommendation, whichever I said so far, are developed based on reviewing existing guidelines from the leukemia bone marrow transplant program of British Columbia, and ACSM's guidelines, and Seattle Cancer Care Alliance, and few more guidelines. Next guideline is based on the physiotherapy intervention to patients with multiple myeloma with lower WBC counts. Patients with neutropenia or leukocytopenia should wear a face mask and wash hands thoroughly ambulating in the hallway and or crowded areas. And physiotherapy equipments should be properly sanitized before being used for patients with neutropenia or leukocytopenia. And for patients with the neutropenia or leukocytopenia, physiotherapy sessions should be preferably provided in the patient's room rather than in the therapy department, specifically to reduce the risk of infections. Next, I want to explain about a few things here. WBCs, white blood cells, and the main role of WBC is to defend our body against infections. And WBCs are classified into granulocytes, lymphocytes, and monocytes. And like all these cells use different types of mechanisms to defend our body against infections. The normal counts typically are between 5,000 and 10,000, and an increase in overall WBC is referred to as leukocytosis, and a decrease in WBC is called as leukopenia. And a decrease in neutrophils, especially, which is a kind of granulocytes. A specific granulocytes is neutrophils. So when there's a decrease in the neutrophils, it's referred to as neutropenia. So neutropenia is an expected side effect of chemotherapy and is often present in patients with multiple myeloma. Although asymptomatic neutropenia is not a medical emergency, neutropenia increases the risk of viral and bacterial infection. And febrile neutropenia is an oncologic medical emergency, and patients with febrile neutropenia are often admitted in the hospitals for antibiotics and for supportive measures. And there are no specific exercise recommendations has been found in the literature for patients with leukopenia or neutropenia, but we recommended the action statements which I discussed a few minutes before. It's primarily to prevent infections, because patients with neutropenia or leukopenia are usually immunocompromised, and as we all know, face masks and hand hygiene plays a major role in reducing the risk of infection. And in addition, we strongly recommend that physiotherapy equipments are thoroughly sanitized before and after use by each patient, and we recommend additional caution and thorough sanitization of all the physiotherapy equipments walkers, wheelchairs, anything that are used for patients with multiple myeloma. And the main role is to prevent infection. Physiotherapist, the sixth recommendation is about providing physiotherapy interventions for patients with the risk of fractures and who have vertebral fractures. So physiotherapists, the recommendation is that the physiotherapist should consult with physicians regarding risk of fractures and weight-bearing status, and take precautions, appropriate precautions, and adapt exercise and modify the exercise using their critical thinking skills and clinical judgment in prescribing exercises in patients with multiple myeloma with bony lesions. Patients with multiple myeloma often present with bony disease, and this is referred to as myeloma bone disease, MBD. It can affect any part of skeletal system. It could affect your spine, it could affect your skull, and it could also affect the long bones, resulting in bone pain and increased risk of fractures. Bone disease in multiple myeloma is different from other bony metastasis. If you remember the osteoblast and osteoclast physiology was talking to you at the beginning. So in multiple myeloma, the formation of cells or the cells are also affected. That's the osteoblastic activity is also impaired. Whereas in the other type of cancers, the osteoblastic activities are there. So there are new formation of cells, bone cells. But because the resorption rate is more than the bone formation, that's when they have the risk of fractures. Whereas in multiple myeloma, both are impacted. The rate at which the new bones are formed are also reduced, and the rate at which the bones resorb are increased. So it's a combination of reduced osteoblastic and increased osteoclastic activity, increasing the risk of fractures. It is estimated that 70 to 80% of patients with multiple myeloma suffer from bone pain, and 50 to 60% of patients have fractures, and 2 to 3% of patients have spinal cord compression. Evidence shows that exercise improves physical function in patients with cancer. However, it's important that taking additional precautions and modifications are necessary in developing exercise regimen for patients with multiple myeloma, specifically because of their increased risk of fracture. And bony lesions are not absolute contraindications to physiotherapy interventions. However, components of the exercise prescription should be modified, and additional precautions should be incorporated to minimize the risk of fractures. Example, like avoiding high impact activities, like because as the bones are weaker, and avoiding end range of motions, like avoiding increased forward flexion or increased backward extension, like overreaching activities, twisting activities, and in the any compressive forces or shearing forces. Those kind of activities should be avoided, and it is important that patients follow back care principles and use appropriate mobility aids. If a therapist recommends walker, it's important that the patient uses the walker. If the therapist recommends cane, it's important the patient use the cane to minimize the risk of fracture. And physiotherapists should avoid the exercises and activities that include the movements that we're talking about now, and should also avoid excessive pushing, pulling, and weightlifting activities. And it's also recommended that physiotherapists use their clinical judgment and their expertise and modify the components of the exercise to fit the patient's need, because every patient is different, their severity is different, the level at which the fractures are different, so they have to use their clinical judgment and their critical thinking skills. So the next question is it okay to do exercise before receiving stem cell transplantation? The short answer is yes. The clinicians may offer home-based, unsupervised aerobic exercise to patients with multiple myeloma increase their cardiorespiratory fitness and their physical activity levels during the ambulatory period before receiving this high dose stem cell transplantation, which will improve their endurance and their strength. The second question, and the next part of the action statement is about, is it okay to exercise during receiving stem cell transplantation? And the short answer is yes. Clinicians may offer supervised mixed exercise program consisting of aerobic and strength training exercise program when they are admitted in the hospital or when they receive chemotherapy as an outpatient setting as well while undergoing chemotherapy. And generalized rehabilitation exercises, aerobic exercise, and strength training exercises are provided especially to increase the functional mobility, functional activity, and their physical performance. And the exercise intervention during treatment is also found to improve their quality of life and reduce fatigue. It also improves the muscular strength. And it's important to note that clinicians may offer supervised mixed aerobic strengthening training exercise to patients with multiple myeloma with fracture risk or skeletal issues. And clinicians may offer home-based exercise training that is unsupervised. So the item number 8 is about supervised, and item number 9 is about unsupervised. That's home-based exercise training. And sorry. Okay. Similarly, it's mainly provided to improve the nighttime sleep and decrease the fatigue during chemotherapy. And it's also found to increase or maintain the aerobic capacity and improve the physical activity during the treatment sessions and maintain lean body weight and muscle strength. This part of the guideline is about, is it okay to exercise after receiving stem cell transplantation? Short answer is yes. Clinicians may offer supervised or unsupervised individualized exercise training using, based on strength training or aerobic exercise training in an outpatient and or home-based setting. And you're medically stable after receiving stem cell transplantation. And this type of intervention are found to increase quality of life, decrease and improve the physical activity level and the physical fitness level and the functional ability. So once these recommendations were developed, the draft guidelines was assessed by 4 pathologists using agreed to tool, and it was also reviewed by O program in evidence-based care from McMaster University, and the final guideline was endorsed by Canadian Physiotherapy Association. And here is the result of our review process. If you see, all the 4 methodologists gave a good review of 6 to 7, and they recommended the use of this guidelines. I'm open for. Thank you very much for listening to me all this time, and please shoot any questions you have.
Hi, thanks Deepa. Thanks so much for explaining on for giving us all of these recommendations, or teaching us all, or I guess informing us of all these recommendations, and also on how they were developed. I think that's very important to note that these weren't things that were just taken from one person or one thought. It was really a group effort. It was based on evidence. And so congratulations and kudos to you guys for being able to get these out there. Now, I guess from a global perspective, these research questions, how did they come about? Did you guys in your practice notice that there was perhaps a lack of knowledge in how to provide physiotherapy to myeloma patients?
Yes. When I started to work in the oncology unit, I tried to look for some recommendations, and I couldn't find anything specifically. So I'm very much interested in multiple myeloma because I have a personal a family member who had multiple myeloma. So I'm very much interested in multiple myeloma. I'm trying to find some evidence to support what I'm doing with the patients, and I couldn't find any. So I gradually learned from from multiple searches, researches. I finally I was able to come up with the good idea about this is what I'm doing. But then if I'm off, somebody comes in my place to replace me for a few days or something, they'll be left with nothing. They don't know because they are not in oncology. So when you work in oncology, you basically learn about it because you do research, right? But because there is no evidence available, it's pretty difficult for a physiotherapist who fill in for me, plus any novice physiotherapists who step into who are interested in working in oncology. It's pretty hard for them because there is no evidence available. So we found the gap. Now the question was how to fill the gap. So that's when we thought, let's develop the guidelines ourselves. Our team included oncology physicians. We had a hematologist, Dr. G. He's a great hematologist. We are so fortunate to have him here at HSN. His feedbacks were pretty helpful. And Dr. Knight, he's an amazing physician, He was always available for any input that we need for this research project. And we also had exercise physiologists and research methodologists who all helped us to develop this evidence-based guidelines based on the evidence plus the consensus process, because for one part we didn't have evidence at all, so we had to go solely through the consensus process, and we need some guidance because we can't just do it, right? We need some guidance. So the whole team came together and we developed the research question. We discussed of the steps we are going to do, and that's how this guidelines was developed. And we are pretty happy about the guidelines because we included physiotherapists from multiple areas in Canada. So once this guidelines was developed, we were able to send it to them, and they were happy because their inputs were taken into consideration, right? And we were able to we revised our draft guidelines based on their inputs. Plus, because they have participated in it, they recognize it. And they said, one of the physiotherapists told me that so far they always had some, they didn't have anything to back up what they're doing. So now they have something to show the patient. Yes, you know what? And the patient says, no, I have a vertebral fracture because of multiple myeloma. I don't want to do the exercise. So in that case, they had the evidence to show, no, it is helpful. It's going to be beneficial to you when you do the exercise.
That's great. Thanks for all that background. We have a question here, and I think it's a good segue into one of the questions I was going to ask you. So the question is, do you know if there are any studies that explore how physiotherapy and fitness consideration in people who are perhaps a little bit younger, so maybe in their 50s or under 50, that are potentially stronger and healthier prior to a diagnosis? So I guess the question is, are there studies that have looked at or that are looking at how physical fitness and how exercise before treatment can help you post-treatment or something along those lines? What do we know? What does the science tell us about physical strength and exercise and treatment?
Yes, that is what we try to address I think it's question number 7. So any exercise, when you're strong, when you're physically strong, you're strong enough to undergo the treatment. And if I'm pretty sure there are lots of studies available. I just can't, I just don't remember on my back of my mind to tell which study, but I'm pretty sure there are lots of studies available. And exercise intervention is pretty helpful in in improving the cardiorespiratory status of a patient, so that they're physically fit enough to undergo the treatment.
Mm-hmm. And then they'll have a greater quality of life, of course, because of that. Yes. Okay. Another question here, it says, can a physiotherapist use a TENS machine and ultrasound?
Okay. In our guidelines, we did not incorporate the modalities. We specifically talked about the exercise intervention because not everybody uses the TENS machine in their acute care setting. Especially if you take our setting, we don't have electrical equipments to use it during their acute care setting. So we primarily focused on exercise, but I'm pretty sure there'll be some evidence available when you do a research. I'm pretty sure there'll be some evidence available, and it's about, so when you see supporting articles, you have to look into the other aspects as well, like based on which population they have administered that particular modality. Then you'll be able to know whether that's applicable to you or not.
Okay. Thank you. Another question here is asking if a particular type of exercise would be potentially considered safe or unsafe for someone with myeloma, and the exercise is Bollywood exercise. Would that be something that would be contraindicated, or it's on a case-to-case basis?
It's definitely case-to-case basis, because not everybody is same. Every single patient is different. Their severity is different. The location of the fracture is different. Mm-hmm. So it is definitely case-to-case basis. And like any exercise, if the physiotherapist has a doubt, it is always good to consult with the physician. Mm-hmm. And another thing is like the weight-bearing status and the use of assistive devices, and all these are based on consultation with the physician. Yeah.
Okay, great, thank you. So basically, there's no way that a person can know if a particular exercise is safe for them unless they consult a professional.
Yes.
Okay, great, thank you. Now the next question I have here is that we did that. Okay, so now we talked a little bit about it before. The definition of exercise, so you're going to come across myeloma patients who are very fit and who go through a stem cell transplant, and they're very strong and they come out good and have a good quality of life. But you're going to have the ones who are less fit, who cannot do less, and so they say, oh well, I can't do anything because of my disease, because I have pains here, I can't do this, I can't do that. And so what's the definition of exercise? Can for that person who can't run a marathon, or who can't do really strenuous activities, how can they exercise?
To me, exercise means any form of physical activity. For example, it's like if you remember, I was talking about platelet counts. When the platelet counts are less than 10, we recommend essential ambulation and some activities in lying, which means that like moving your arms and legs, that would help them to maintain their level of function. So plus when a physiotherapist recommends exercise, it's not random. They recommend exercise based on your ability and based on their blood levels, because I wouldn't do a strengthening exercise for a patient whose platelet levels are less than 10. Mm-hmm. And I would start with using resistance only when their blood counts are more than platelet levels are more than 20. So it's all depends on your blood values and your ability. And when it comes to exercise, it includes the dosage, it includes the type of exercise, and it includes the amount of resistance, it includes the amount of number of times, frequency, duration, how long you should be doing that exercise, and how many times you'll be doing exercise. So when it's prescribed by a professional, it's going to be, it has a dosage so that it can be progressed from one level to the another level. It's not just random activity. So so this guidelines helps the physiotherapist to determine what can be done safely for a patient who has multiple myeloma, who was admitted in the hospital, and who received or receiving or going to receive stem cell transplantation.
And that's a good way to. I think that brings me to my next point, my next and last point, because it's 2 o'clock, and so the webinar is pretty much finished. But you know, in your experience, you know, you have that patient that can barely do any activity. You know, and you know, as you said, the dosage, you slowly increase it and make it higher. Do you have, you know, have you seen patients who started off with baby steps, very slow, and have been able to regain lots of strength and become mobile and completely different than the way they started? You know, can you maybe share with us some stories of hope, or some you know?
Absolutely, I would love to share. Like, I have been working in the unit for almost 6 years now, so I have seen different range of patients. Like one patient, he was a young patient. I can't remember. I think he was in his 60s or something. He received stem cell transplantation. He was pretty weak, actually, very, very weak, because the chemotherapy took a toll on him, and they couldn't send him home because his levels, his platelet levels didn't increase. It was up, and it takes 2 to 3 weeks to go up, but for him it was very, very slow. So after I think he was here for 4 or 5 weeks, you know, 1 or 2 weeks more than the typical patients. So during the time, we followed this guideline, and we were able to progress very slowly. And as the blood counts increased medically, when he received the supported treatments medically, he was able to progress physically as well. And by the time they determined his platelet levels was around 50 or something, his functional ability was pretty good. Like, he was able to walk better, his endurance improved, the speed improved, and he told me that he feels very strong. He was able to sleep well at night. That all gives you energy to participate more during the daytime. Mm-hmm. So eventually he was discharged, and he told me, before he went, he told me, like, he has come across a long way, and he was strong enough to live by himself. Before he came here, he needed help for his functional activities at home. He was supported for all his IADLs, like instrumental daily activities of living. He was supported, but by the time he went from here, he was pretty strong enough, and they had to, you know, still keep him here because of his up and down fluctuations with the blood counts, actually. Mm-hmm.
Well, it's definitely nice to hear that, you know, like, you know, someone might be discouraged, you know, they might not want to do the workouts, but there is a light at the end of the tunnel, and never to lose hope, I think, is the moral of the story.
Yeah, exactly.
So with that, I'd like to thank you again for taking the time to present these recommendations to us. And like I said, it's recorded, so people can go over and they can look at it in the future. So thanks a lot, and I wish you a great rest of the day and a nice weekend as well.
Thank you so much for providing me the opportunity to present my work. Thank you so much, and thank you so much, everybody, for paying attention and listening to me. Thank you. Have a good day, everybody.
Have a great day. Bye-bye.